the emergency medicine channel. Today I will be presenting a case of a 39-year-old male patient who presented to our ER with alleged history of deliberate self-harm with intake of Borigan 25 mg sachet, which is a Cartap HCl compound, at 11:30 a.m. in his home, and followed by that he was having complaints of vomiting, abdominal pain and loose stools. And he went to outside hospital. There right insertion was done and gastric lavage was given, and ABG outside showed metabolic acidosis, and they started on bicarbonate and NAC infusion, and they referred here. On initial 10-second assessment in ER, patient
Cartap is used for which all?
Used mainly for the paddy, like rice paddy or sugar cane crops or any cabbage, cauliflower. And
it's not a very commonly used pesticide. That's why we are not getting cases like this.
And on initial 10-second assessment in ER, patient was conscious, oriented, talking in full sentences. Airway was patent, there were no secretions or gurgling of sounds. Breathing wise, air entry was bilaterally equal, saturation of 97% on room air and respiratory rate of 24 per minute. Circulation wise, BP was 120 over 80 millimeters of mercury and heart rate of 120 per minute. Disability wise, GCS was E4, V5, M6, pupils equal and reacting to light 3 millimeters equal, and GRBS was 126 milligram per deciliter. Exposure wise, temperature was 79.8 degree Fahrenheit. Adjuncts of primary survey, ECG showed sinus tachy, 97.8 degree Fahrenheit. Adjuncts of primary survey, ECG showed sinus tachycardia, and QTC was 452 milliseconds. And ABG taken showed.
What are the problems of heart rate and other things in this case? What are things we have to observe in this patient? Any poisoning, there are some toxidromes. It will be very difficult to understand from the toxidrome. This is a case of this poison. And even then, what are the things we have to look for?
In this case,
In
this case, patient can present with mostly it's this Cartap HCl compound is a nicotinic receptor, postsynaptic nicotinic receptor blocker, which is a neuromuscular blocker. Basically. So basically, the patient can present with symptoms of like this vomiting, abdominal pain, diarrhea, tremors, seizures, or any respiratory failure, respiratory distress, muscle weakness, spasms can be present with. Metabolic acidosis,
water sensors and motor-active nicotinic receptors. Water
sensory can
low GCS issues. Metabolic ABG wise?
ABG wise respiratory alkalosis can occur due to the respiratory distress, and then acidosis, metabolic acidosis can occur.
Initially respiratory alkalosis, then later metabolic. There are a lot of poisons like that, multiple type of ABG abnormalities.
In this patient, pH was 7.365, and the PCO2 levels, partial pressure of carbon dioxide was 26, partial pressure of O2 was 94, and bicarbonate levels were 14.9.
So he is going for
metabolic
acidosis with early respiratory alkalosis. Sorry, early respiratory alkalosis going for metabolic acidosis.
And the lactate was 3, and anion gap of 4. And coming to the secondary survey, 39-year-old male patient who was he was actually working in a cooperative society bank. And
what is the reason for this lactate being high?
Because it's respiratory effort, which is
tachypnea can cause the
muscle use.
The patient is working in a cooperative society bank, and from there he had got suspended due to personal conflicts with the staff over there and financial issues. And after that, he was having complaints of low mood, reduced sleep, and reduced interactions with family. And after that, he had gone to the terrace and he had taken Borigan 25 mg sachet, which he mixed with Pepsi, and he had in an attempt for a deliberate self-harm. And he had followed by that, he had 3 episodes of vomiting and 5 episodes of loose stools, which was greenish colored, watery in consistency, with associated central abdominal pain, which was continuous, associated with blotting episodes. And also it was mild to moderate in intensity. And he was taken to outside hospital by his mother, where RT insertion was done and gastric lavage was given. He presented to outside hospital in 2 hours. And after that, ABG taken from there had showed a picture of metabolic acidosis. And he was started on soda bicarb and N-acetyl cysteine infusion. And due to persistence of symptoms, they came here for further management. There are no
What are
history
the
of
indications of sodium bicarbonate in any patient?
sodium bicarbonate if the pH is less than 6.9 or bicarb less than 8.
Otherwise, is going to help the patient. Soda bicarb
It
base
will be converted to PCO2 and take.
In
normally
patients,
it creates more problem than what we think. Okay.
Gives the buffer time so that the heart will not go.
It only helps in a cardiac issue. When the patient is having a cardiac issue, like he told, it can give a buffer time. That's all. Otherwise, most of the time, soda bicarb itself will worsen the patient's general condition. So never try to correct that acidosis with soda bicarb. You can go for other alternative methods to correct. If nothing is working and patient is cardiologically deteriorating, then you can try.
patients
Diarrhea.
causes of loss of bicarbonate,
We cannot overcorrect it to make it to a normal acid-base balance. We can like half the dose
Whatever
only
is lost,
prescribe. Whatever you calculate the total bicarbonate deficiency, in half only we should correct. If you correct full, then you are actually overcorrecting it. So you can only support the patient just for cardiac. It can produce cardiac like stunning. So you can only prevent that. Never try to correct fully with soda bicarb.
And this patient, there are no history of any altered sensorium, fever, cough, breathlessness, dysuria, chest pain, palpitations, syncope, blurring of vision or spasm. There are no allergies to any other medications in the past. Past history of chronic alcohol intake is present, and last meal was taken 1 day back. Systemic examination wise, per abdomen examination showed it was soft, but there was tenderness in the right and left lumbar regions and umbilical region. Rest examinations were within normal limit. And we had sent initially routine lab investigation, which showed a total count of 14,000, CRP of 129, procalcitonin of 19.6, and urea showed 52, creatinine of 2.73. HB was on the higher side, 17.4, with a packed cell volume of 52.7, and platelets are 1.73. And the total bilirubin.
Abnormalities you are seeing in this.
The effective markers are elevated. HB is on the higher side due to dehydration most probably, and PCV also on higher side, 52.7. Creatinine is deranged, RFT is deranged, and also LFT wise, total bilirubin was 2.73, direct 1.46. OTPTs were 250 and 200. So there is also transaminitis and hyperbilirubinemia is present, and INR is 1.15. And we had initially already patient was on Piptas from outside hospital, the present as a back, and we had continued on that same antibiotic. And
so what infection you are anticipating?
Patient was having complaints of vomiting and diarrhea. Apart from that, there are no other symptoms of cough or breathlessness. There was mild tachypnea on arrival, but X-ray showed only prominent bronchovascular markings, and no other complaints of dysuria, and urine also showed 0 to 2%. And only symptom here was of the gastroenteritis, secondary to mostly the toxin. So maybe the source might be that. So gram-negative coverage.
Do you think that procalcitonin always indicates an infection?
In inflammation also,
Non-infective
non-infective
lung problem itself it can elevate procalcitonin. We have seen many patients without any infection. Sometimes procalcitonin can be elevated. So if there is, you are not suspecting any infection, and if the procalcitonin is elevated, you have to see any other alternative sources are there for procalcitonin, especially lung injuries, all these things.
CKD kind of things.
So many conditions procalcitonin can be elevated. When you are not suspecting an infection, this is a toxicology case. Recently he has taken 1 day back, he is not intubated. Diarrhea can be due to this toxin itself. We have to be very sure that whether there is any infection or not. Anyway, we cannot avoid antibiotic because we are treating the patient acutely. We may have to send other investigative methods to rule out an infection.
And this patient we had started on already gastric lavage was done from outside hospital within 2 hours, and here he presented after 1 day.
What are the conditions you avoid gastric lavage?
Gastric lavage we should mainly avoid in patients who have low sensorium because of risk for aspiration during the gastric lavage.
hydrocarbon
Acid base
acid
Acids
or
or
alkali.
bases.
So that you should avoid. Other things, all you can even try. At least you can put a right.
Sensorium
Even
help
the,
me intubate the patient and we can-
even if the patient is sensorium is low, like he told, intubate and do the procedure. But acid or alkali, it is better to avoid putting any tube inside.
And then we had started, according to the available articles, there was only limited studies available based on this compound, Cartap. So we had, according to the evidence, mainly the management is gastric lavage. And supportive managements mainly based on the mechanism of action we can do. So basically, there are two mechanisms of action mainly described in textbooks. So one is the, as you said, postsynaptic nicotinic acetylcholine receptor blocker action, which is basically the neuromuscular blocker action. And but in some animal studies, it had shown that the exposure mainly caused a reaction like it blocks the ryanodine, it inhibits the ryanodine binding to the calcium release channels, which is the calcium ATPase in the sarcoplasmic reticulum, which is the muscle reticulum. So when it blocks the ryanodine binding, it causes the calcium influx from the outside of the cell, and internally the calcium gets released inside, and this causes increased calcium levels within the cell, and that goes into tonic contractions. So in the diaphragmatic muscle, if it happens, it can cause tonic diaphragmatic contraction. That is one mechanism they had devised. So in those cases, so what we can do is we can chelate the calcium with the help of chelators, like we have the British anti-Lewisite, or we have DMPA compound, sodium dimercaptopropanol, penicillamine, D-penicillamines are available.
So which is available here?
Then N-acetylcysteine,
No,
we can
N-acetylcysteine.
give that also.
Among these three things, which is available?
D-penicillamine.
D-penicillamine is available. Which other condition we use D-penicillamine? Any rheumatic disease we use? Skin disease? Scleroderma, one of the treatment is D-penicillin. That's why it is available in our hospital or market. It is widely used. But sometimes that is also not available.
So this patient we had started on N-acetylcysteine infusion, which was available, and we had given 150 mg per kg in 200 ml D5 water over 1 hour, and then 50 mg per kg in 500 ml D5 water over 4 hours, and 100 mg per kg in 1 liter D5 water over the 16 hours. So total 21 hours infusion we had started. Then we had put on 600 mg TID dosing. And also, since the patient had a higher SB count, we are suspecting dehydration. Orally also the patient was dehydrated. So we had started patient on fluid. Trinclactide was started because patient was having already vomiting and diarrhea. And trinclactide was started at 150 to 200 ml per hour. We are titrating ND. And already, and also Bifilac and supportive measures, Bifilac, Cartap was given. And after some time, patient had progressively there was the acidosis improved, and creatinine and CRP levels improved, and blood culture also we had sent that showed no growth, and the loose stools consistency also gradually improved, and psychiatric consultation was also done, and we are advised to start on metrazapine 7.5 mg. So basic management is the gastric lavage and N-acetylcysteine. What we can give as adder measures.
Tell something about gastric lavage. That is the most common thing we have to do in toxicology.
Gastric lavage is best done when the patient arrives within 1 hour of ingestion, until it is a sustained release preparation. In this
what
case,
other conditions you use extended like you can use for even more time?
More time if it's heavy dose, large dose of ingestion, or the preparation is sustained release preparations, or the patient having low transit time, like in Parkinson's conditions, diabetes, gastroparesis conditions, and all, there will be lower transit time. So patients we can give for up to 6 hours also may be effective. Then we usually in gastric lavage we'll insert a tube, Eval's tube. Eval's tube is available as adult and child size. Adult size usually we give is 36 French.
And it is not trial tube, that we should remember. Normally we all do trial tubes, that is not the ideal thing. But that may not be available in all centers.
Child it is 24 French. It's painful procedure because of the large diameter. 24 French in child. So we'll instill tap water and distilled water in the saline we can use for washing it. So we'll give it, flush it, and then we'll suction it back, and we'll clear the contents in the stomach.
Activated charcoal.
Activated charcoal we can give also in this patient if we
There is
present within 1 hour.
activated charcoal.
So initially the loading dose will give us 1 to 2 gram per kg for adults, and max dose of 50 grams we'll give by mixing it with water or any fruit juices. We'll mix it, and ideally it should be given through the rice tube or the well tube we can give. And multi-dose activated charcoal is used for patients who have as we said, larger dose of injection, or there's like sustained release preparations.
Whatever you explained in the previous one, all the same
Same
larger
patients.
doses, sustained release or
So after-
lower transit time.
So after the initial dose, loading dose, we can give it as like 12.5 grams per hour. We can give as in multi-dose activated charcoal. And in low sensory patients, we should avoid.
Okay.